our conversation around transportation as it pertains to healthcare, and we have with us Jim Moulton. And he's going to talk to us about Medicaid transport. So thanks for being with us.
Thanks for having me. So I am Jim Moulton. I am the Executive Director of Tri-Valley Transit, the transit provider for Addison, Orange, and Northern Windsor counties. I am also the chair of the board for the Vermont Public Transportation Association, which is the trade association for the state's public transit providers, and is also the contractor with the Department of Vermont Health Access for providing Medicaid NEMT, non-emergency medical transportation. So I'm glad to be here and happy to answer any questions that you have about Medicaid and NEMT and anything else.
I think maybe if you can just explain sort of the role of.
Sure. So Medicaid transportation is for Medicaid recipients. There is a provision about transportation specifically in terms of whether people have vehicles in their houses or things like that. But for the subcomponent of all Medicaid clients, those who have transportation needs that they can't fill themselves, we are the provider system for that. We get people to all of their medical and medically related appointments, and that can range from just general physical checkups to pharmacies to kidney dialysis to cancer treatments, the full gamut of medical services that we all might want or need at some point in our lives. The regional providers like Tri-Valley Transit cover each of their own areas. The primary contract, again, is held with VPTA, but the Medicaid riders would contact the local providers to arrange their rides. And then we try to provide those rides through the least cost mode that is appropriate for that rider. An example of that might be someone who has mobility limitations, might require a lift-equipped van. Somebody who is relatively mobile, we would probably look to put them in a car with a volunteer driver. We look to cost share whenever we can by putting multiple riders in cars. We partner with our other programs. We are primarily across the state public transportation providers, and so there's a lot of bus routes and other services that we provide under the Agency of Transportation, but we share those costs with Medicaid and try to keep costs for both arenas down. Medicaid is an entitlement program, which makes that's one unique element to that. When people need their medical transportation rides, our purview is to provide the ride regardless. There's another program which you may have heard about in other times for the under the Agency of Transportation for older persons and or persons with disabilities. That is a program, because it's funded through the Department of Transportation and the FTA, there are limits that are allowed to be put on that, which can often be financially constrained. Medicaid, however, is entitlement, and so we have to find ways to provide all the rides, regardless of the ultimate cost. Again, our focus is always on looking for the least cost mode that's appropriate for the individual riders. I did mention volunteer drivers. I'm happy to pause if there's any questions at any point.
Let's pause for just a moment. Woody has a question.
Sure.
Yes, I'm looking at your website, TVT, if that's it.
Yes.
And I see where there's a great many, well, maybe not a great many, but there's a number of fares that have been suspended on your bus routes and things like that. Who's paying for this? For these fares that are no longer collected?
So fares are a little bit distinct from.
I know it's different for Medicaid,
okay.
Transportation.
All right, I just wanted to make sure.
But
right.
Obviously, it's hurting your bottom line, probably, isn't it?
Well, so I'll backtrack a little bit to give you some perspective on fares. Pre-COVID, many of the providers around the state did charge fares on their bus routes, on their fixed bus routes. When COVID came, it was one of the first implementations for safety purposes, especially when no one sort of knew how COVID was being transmitted. We wanted to create contactless ridership. During the COVID years, there was a study done by a consultant who was working for VTrans. And that study was specifically around fares, not only how many revenues had been historically collected from fares on bus routes, but also what the actual cost of collecting the fares was. The simple version is that the study came down to there's urban and there's rural. Urban obviously being the Burlington area. For the Burlington area and for municipal urban areas around the country, it makes sense for fares to be collected. The volume of ridership and the price you can charge for fares exceeds the amount that it costs to actually collect those fares. Costs are anything from the fare collection software or hardware that's on the vehicles, the cost of the extra time for driver interactions, the cost for selling fares or implementing the media for that, security for the fares, et cetera. So there's a lot of costs associated with the collection of fares. But as I mentioned, in the urban areas, that the collected fares typically exceed the cost of fares. The study did reveal that, at least for Vermont, because it was a Vermont limited study, the cost of fares was greater than the money actually collected. So it actually became a financially prudent decision to remain fare free because it actually reduced the cost more than the fares that were being collected. Happy to answer any other
Well,
elements.
Thank you. I know we got off topic, but I just saw that and I just thought,
Yeah, that's the reason if you not just TVT, but if you went and looked at the other provider,
yeah,
non-urban providers, you
Burlington,
would
I
see the
think.
same thing. But that was a conscious decision made coming out of post-COVID. The Agency of Transportation does support a lot of what we do with both federal and state funds. And then we also every provider around the state also has to raise a lot of local funds to help draw down those state and federal grants. So there's a mixture of funds that do pay for it, but the fares actually, it was ironic to learn that they were actually a detriment financially to the rural providers.
Can I just ask, because I'm trying to go back in my memory here, and if I'm completely conflating you with someone else, please let me know.
Sure.
But if I recall, for Medicaid, non-emergency medical transportation, you were paid by the individual per month, per member per month. And I'm seeing a memory of graphs where actually your ridership was going down, or your individuals you were serving were going down, but the rides you were providing were being inflated. Am I right? Is that how you're funded through Medicaid?
That's awesome that you can
Can't
pull
believe I
that from
remembered that.
memory from a year ago. Yes, so the payment mechanism is we either refer to it as per member per week or per member per month. The original mechanism was to be on a monthly, per member per month, but we actually do get reimbursed or paid every week. So we often refer to it as per member per week. And it is exactly that. It's for each individual member, there is a set amount of payment that comes through, and it's the math. The revenue side of it is the math is simply how many members are in the system who are eligible for Medicaid transportation times the rate. The one piece of information that's critical about the number of members is if a member has taken a Medicaid eligible ride within the past 12 months, they are counted. If they go 12 months without receiving a ride, They still could be technically eligible for ride, but if they don't receive one, then they aren't included in that count. So as you noted, there's been changes in the number of members. That's been, due to COVID was one reason. Administrative oversight was one reason, especially during the COVID years where the federal government was actively saying, you don't have to abide by all the, rules and regulations, all this and all that. But in the last, certainly at this time last year, there was clearly evidence that the number of riders had been reduced. It's been relatively stable this particular year. So we haven't seen a continued decline, but that is the methodology that gets used.
If I recall, weren't you working with DIVA on an alternative payment methodology?
So we are in regular communication with DIVA during the course of the year. There has not been developed an alternative at this point that we've been in specific discussion around, but it's not something that we're not interested in. The last year in particular, there was a change in the rate, which helped to draw down the funds, but the mechanism itself at the moment continues to be the same.
Leslie, did you have a question?
So my questions are really along the same thing. I was trying to recall from last year, and what I remember was quite a significant deficit that you were working under. And that was my question is, how has that worked through? And maybe you answered it and I didn't understand, but I just was wondering about the stability of the program at this point compared to last year.
Great question. So we have been gathering our first 6-month data, and we're going through, we've typically at this time of year, we have a consultant then look at the data and analyze what the trends are. At the moment, we are experiencing some losses through the end of Q2, so through July through December. But we haven't been able yet to look at the trends to determine what that projection might look like by the end of June. So we've got Q3 and Q4 still to do. The annual review that I just mentioned is in process right now. And I think either one of you referenced some of the trends from last year, which is that even though the number of members was going down, the utilization of individual members was going up. The number of rides that any person might be taking was increasing. So when, if we're getting paid still for one individual member, but they're taking twice as many rides, the cost goes up roughly double, but we're still getting the same revenue. So that was a big issue last year. We're looking at this year what those trends are. But there, we might look to come back to the committee a little bit later in the session once we have that analysis in hand and share that information with you. But for the moment, it looks like there's some losses through Q2, but we'd like to understand what the driving forces are, what we have control over, what we may need to address in different ways.
So may I ask?
Yes.
If that means that you're coming back with a budget request, that would need to be within a certain timeframe? So just to get that out
Yes.
there.
No, we absolutely
Probably all over it.
heard and understood. Last year we obviously were engaged in these conversations as well, and so it is something that we're very cognizant of. As I mentioned, the consultant has the information, is working through the analysis and report. So, hopefully we'll have that in the near future. If we're fortunate, then we don't need to come back for any additional funds. That'd be great. I'm just not in a position to be able to say what that trend looks like. Obviously there have been a couple of big changes in costs as of, the first of the year. Everybody's feeling it, healthcare, health insurance. But we don't yet know the impact, and we're not yet looking at that impact. So
Thank you.
you're welcome.
Thank you. Yes, of course.
Does your providers, I guess I'll call them,
Sure.
do they do anything with the schools in providing Medicaid transportation?
So that's a great question. I smiled in particular because I've been asked by the House Transportation Committee to speak before them on Thursday specifically about school age transportation. So for Medicaid riders, if they're school age, then we would provide those trips under the Medicaid program. So they may be going from school to some kind of medical service, and then we wouldn't be required to try to provide that. The way that happens, would be the same as anything else. There would be, probably family members calling in, guardians, potentially case managers, making arrangements for the rides. We would pick them up at their school systems if that's where they were, or when they were getting their service, and taking them. A lot of the providers, and Tri-Valley Transit is definitely one of them, do also provide a fair amount of school age transportation on our regular bus routes. Many schools are on, what would be well-traveled corridors for commuters or residents, shopping centers, and we have built many of our services to make sure that we are providing the maximum amount of transportation for the general public, including school-age children.
And so would that include getting those school-age children to school?
Yes, it can be to or from school. They're from designated stops. It's not door-to-door service. It's not like yellow school bus transportation. That, is still a large part about how many people, certainly around Vermont and around the country, have their school children. But we have designated stops. Those are vetted for safety purposes by providers. And so if there are school-age children waiting there, and we can go by their schools, then that's how the transportation occurs.
And do you mind if I keep going?
No, keep going.
And do you then bill that through a different channel, right? So is it Medicaid through the schools that you bill? Or how does
So
that-
if they are specifically for Medicaid, so part of the Medicaid eligibility is that the rides themselves have to have a medical purpose, a medically approved purpose. So if the child is just riding to and from school and not going to a medical appointment, then that would be considered general public service and would be allocated to that cost. If they are still going on the bus system, stepping back for a moment, when we think about the least cost, most appropriate mode, if there's a school-age child who could be picked up, let's say it's an after-school appointment from the school, and their medical provider is along the route, we would look at that and say that is the least cost mode. We would have them go on the bus system to that Medicaid provider. That would be considered, even though the impetus might have been it's a Medicaid trip, because it's on a general public route, we are then looking at the least cost mode, would put them there, and it would be no direct cost to Medicaid. If that child needed to go to a provider who was not near a bus route and had to be picked up with a different vehicle, which could be typically a volunteer driver, or it could be in a lift-equipped van if the child was mobility impaired, and that would then be billed to the Medicaid system.
And the Medicaid system through the school district or through?
No, through DVHA.
Okay,
Correct.
thank you.
You're welcome.
I think I have to get to the number, but I think we have a question from our healthcare advocate, actually. So.
Hello, Jim. Mike Fisher, healthcare advocate here.
Hi, Mike.
Quick question, a quick comment. I remember last year there were discussions about an alternate payment method or discussions about an alternate payment method for very high users. Did anything happen with that?
So that was the question I was looking to answer previously. We have not been in specific conversation with DVHA about that yet. It certainly is a question that is probably good to direct to the DVHA officials because I know that they have been considering different things in the background. in terms of, how to track this information, what might make from their perspective, a logical change for something like that. There have been a couple ideas floated especially in terms of, is there a different rate for the high end users, the high need users, riders. But we do not have, anything that is concretely changed at the moment.
Okay, and then just a brief comment to the committee. Non-emergency Medicaid transport generally is a place of stress where we get a lot of calls from Vermonters who are having a hard time managing this system. And there has been, I just checked in with the team. I was thinking when I saw this testimony that I hadn't heard a lot of cases recently, so I just checked in, and there's been a noticeable decrease in calls for assistance in the last couple of months. I'm not sure that we know exactly why that is, but it's when I can get some good news, it's good to get a little good news.
Right. That is a positive development. We are committed, across the state, to getting as many rides done as we can. The resources are difficult sometimes. I think, you're probably all clearly aware that the labor market in Vermont is extremely tight. Finding enough paid staff members, paid drivers to do all the work is very difficult. Since COVID, although our volunteer workforces have gotten stronger, they still lag well behind, almost 50% behind what they were pre-COVID. There was just a mixture of, truthfully, many of our volunteers are older and frailer and passed away during COVID. Many have moved out of state. Many others have just decided that it's no longer something they can do. We do have a lot of dedicated resources. We partner with the Agency of Transportation on marketing campaigns to rebuild the volunteer workforce. So there have been challenges in that, but the fact that you're referencing that the number of issues of getting assistance has apparently gone down is very positive. I appreciate being able to hear that and see that, because my staff and the staff around the state definitely work really, really hard to make sure that we're providing as many of those rides as we can. We understand how critical they are to people's health.
And Halbert?
Yes. This volunteer workforce that you're talking about, can you define what you mean by volunteer?
Sure. So if you were to be a volunteer, you would use your own car. We would reimburse you mileage expenses under the General Services Administration or IRS rate. That increased from 67 cents last year to 70 cents as of January 1st. So there is a cost involved, but that cost is in reimbursing for the actual mileage that you would drive as a volunteer. You are volunteering, donating your time. So when you drive 2 hours for a round trip, that's the gift that you are giving to the program and to the rider and to the state. However, there's a real cost to you as the driver, to your vehicle, to your tires, your maintenance, your oil, depreciation on your vehicle, insurance, all of those things. And that's the reimbursement we make, so that essentially the capital cost of your vehicle and the operating cost of your vehicle are covered.
In the mileage?
In the mileage rate, yes. So the mileage rate, as I mentioned, GSA, General Services Administration at the federal level, or the IRS, they annually they look at nationwide data and determine what's the average cost per mile. It's ubiquitous across every vehicle type. It's not unique vehicle by vehicle or even vehicle type by vehicle type. So that gets examined every year, and then that gets announced typically in the last couple of weeks of December. And as I mentioned, as of January 1st, that is 70 cents per mile.
Yeah.
To date myself, when I first started this, it was 33 cents a mile.
Now, you mentioned insurance.
Yes.
Now, let me tell you why I'm asking this question.
Sure.
These volunteers are usually older people. And I'm worried about the, the person who's driving the car, the liability that they're carrying, insurance, a lot of times, automobile insurance anyway, they may have just the basics. And that's not gonna, if someone gets in an accident and something tragic happens,
So,
how do you handle that with these so-called volunteers?
so Vermont obviously has a state enforced minimum level of insurance that's required. We ask our volunteers to carry 100, 300, which is what the industry standard, sort of what most insurance agents are looking for their drivers or recommending to their drivers. Beyond that, we, the providers, have our own insurance policies to go above and beyond that. And there are 2 layers of insurance that go above and beyond that to protect the driver, the riders, if there is anybody else involved with any situation that requires insurance coverage. So there are protections in place, and like with every insurance, we all hope that we never need it.
Right, yeah. Okay, so that's included in the contract that you sign with. That's written in there?
The
That's a
insurance,
liability?
yes.
Okay.
It is a standard clause within the contract that we have with DEVA and also with our grants for the Agency of Transportation to provide those extra layers of insurance coverage.
That answers my question. Thank you very much.
You're very welcome.
Does your insurance override their personal insurance, car insurance?
It does not override it. It is on top of it. So any claims would first go through the individual's insurance, and then our insurance coverage is on top of that. But ours go into the millions of dollars.
Right.
Sorry, you were blinking.
You were blinking at my eyeballs.
I know, I was trying to stop it, so I shut it off. My little red thing was in the right place, but now it's like,
Like a beacon light going
Yeah,
over here.
I was even trying to cover it up.
If I might, there's a couple of other items that I think would be good for the committee to be aware of if you aren't already, particularly because obviously cost of providing these services has been a big topic over the last several years. There is a lot of cost sharing efforts that go on around the state. The handout that we generated, I'm not sure if everybody's had a chance to see it because we got it to you quite late. I apologize for that. But the Agency of Transportation in particular provides a lot of funding support that directly benefits the Medicaid program. In particular, for better or for worse, Tri-Valley Transit happens to be the lead agency for the state on a new scheduling and dispatching software program. It's a big project. We are the first provider, and we're in the last stages of trying to put that software system together with the developer, and it'll be spread across the state. This software is critical to the ability of the staff who answer the phones and serve the riders and get them matched up with their drivers. That is being funded 100% by the Agency of Transportation, but Medicaid is a very large beneficiary of that program. They also provide 90% of the capital costs for the lift-equipped vehicles that we operate. There's a 10% what's called local match, and we, the providers, are typically raising the funds for that last 10%, but 90% of the vehicles are funded by the Agency of Transportation. And again, any Medicaid rides that go on that, the operating costs are shared, but the capital costs are borne completely through the Agency of Transportation and us, the providers. Capital cost of facilities is the same. So whether it's the buildings or other elements, garages, equipment, all those kinds of things. As I mentioned earlier, we are always looking to provide shared rides whenever possible. So whether it's 2 Medicaid riders, or whether it's a Medicaid rider and a disabled rider who might be going together. Anywhere that we can increase the number of people in any vehicle is going to reduce the operating cost per person. So there's a lot of collaboration that happens around the state. We even have spreadsheets, shared spreadsheets between providers that we post rides that will be happening for our residents. For example, if there's Addison County residents who need rides in the Chittenden County area, we would post those to see whether the Chittenden County provider could do the pickup and drop off for riders up there. So there are many ways in which we're constantly looking to keep the costs of the program down, and always looking to innovate in those ways. So I just wanted to make sure that you had a full picture of the work that gets done with the providers and with the Agency of Transportation to ensure the stability of the Medicaid and EMT program.
You're a software developer. Is that something in which you're working with Vital?
No, this was done independently. The Agency of Transportation went out for bid we were the lead agency, but it's being primarily driven through the grant funding and resources that the Agency of Transportation has put together. So we have two in particular consultants assigned to the program or project as well to essentially hold the software vendor's feet to the fire. It's a very, I mean, you're probably just aware from past experiences around the state, it can be a long, slow process, longer and slower than anybody wants it to be, especially the software developer. But it's critically important that we get the system designed correctly. We are very close. There has certainly been frustrations, but I am actually quite optimistic at this point that the system we're going to come out with will be a highly functioning system and way better than the system that we have had to use for the past 7 years.
Any other questions from when I had, just because I'm going back and I'm looking at your presentation from last year.
Thank you.
I'm amazed at what I could remember. But one thing, wow.
I can remember more than me. That would be bad.
Well, one of the things that you had cited last year on how your unit costs had been rising was about administrative costs regarding the communications, like I think basically the paperwork you had to provide, and then disruptive riders. I'm wondering if any of that's been alleviated at all, or if you're still seeing challenges with that.
The administration of the program remains a challenge. I'll sort of be very anecdotal in the sense of it feels like every year there are additional expectations that come to us from DVHA, which typically are coming from the Centers for Medicaid and Medicare Service at the federal level. So it's not to point the finger at DVHA as the culprit, so to speak. It's, there are, they go through audits like, every federally funded program. And so those things come down. I think there's often, any one individual thing may not take up that much time, but the cumulative effect of that can be enormous. It's like you add one, pretty soon you're up to 10, 15, 20 new requirements that all take time. And so that is definitely something that remains a challenge. Part of the way the system works, and you may remember this from last year, also, we have an approved cost allocation methodology process within our agencies. It's a requirement of the federal DOT that we allocate costs out to the programs that are served. So we are not in a position to, for example, cost share. It can't be, well, Medicaid is, we're losing money, but we can charge the Agency of Transportation more money for their services and use the profits, so to speak, from there to subsidize. That is illegal under the guidance that we and requirements that we have. So the costs that are allocated to Medicaid are very specifically the costs for Medicaid, their share of those administrative expenses. So it can put us in a bind, and especially because Medicaid is an entitlement program. We, unlike the O&D program I mentioned earlier, we can't put limits on that. We can't say, well, we're coming up against a certain amount of money. We don't have any more money in the budget. You'll have to wait. We can do that under the O&D program, but with the Medicaid program, we can't. So there's always this really precarious balance between how do we make sure we're doing all the administrative tasks that are required? How are we meeting all of the entitlement requirements for the riders? How are we maximizing cost sharing, whether it's capital expenses or individual ride expenses, and trying to keep it within the money that is available through the state and federal programs. And some years have been extremely challenging, like the last couple. As I said, at the moment, it looks like the year that we're in, we might be experiencing some losses, but not to the degree in this moment that, I felt we could come and say, oh my God, the sky is falling. But I do not have any inkling yet what the projections for the next 6 months will look like. And so we may find ourselves asking to come back to the committee and sharing what that looks like.
And Lori, you had
And I apologize, I came in late, so you may have already covered this, but do you have any planning that's happening or reserves should federal funding cease to exist?
So I can't speak for each individual agency. At the moment, I'll speak for Tri-Valley Transit. We are a nonprofit organization. We do rely heavily on government funding. Medicaid is this rough blend of, I think, 57% federal and 43% state. Our general public transportation services are typically 80% federal and 20% state. So there is a high reliance on federal funding. We, of course, like probably most nonprofits, and certainly you as the state, were alarmed by last week's information. We have worked, Tri-Valley Transit, our board and staff have had a long-term strategy of building reserves in place, just as good financial management practices. If there was a short disruption of funds, we would be in a position to be able to continue providing services. That window of time would probably be a few months. But obviously we're all having a very challenging time reading the tea leaves when announcements are made at the federal level as to what is the actual impact. Even clearly the announcement of tariffs on Mexico and China and Canada, Canada and Mexico have come to new agreements, whatever those mean. And so, there might have been tariffs, but there might not be tariffs. And so we are cognizant of what's going on. I've been in close communication with our federal delegation to make sure they understand the reliance of Vermonters on public transportation services and what the disruptions would mean. The delegation, I'm sure as many of you know, or all of you know, is a very responsive delegation. They hear us. It's the beauty of Vermont. We have the opportunity to connect directly with our representatives. And I'm also staying close connection with the executive director for the National Trade Association for Rural Public Transit Providers. Ironically, I happen to be having breakfast tomorrow morning with him. And so he also helps keep us in the loop. They have lobbyists at the federal level in Washington. So from my perspective, we are doing everything that we can to be prepared for disruptions if that is something that happens, to stay in close contact with those who are in the know, those who potentially have influence, and to be prudent with our own resources.
Great, thank you.
You're very welcome.
Thank you. And thank you for coming in. And
Thank you for having me.
have your projections for the next, happy to have you back in.
Thank you. Thank you very
All
much.
right.
We really, really appreciate your interest in what we do and how we do it. As Mike mentioned, it's critical for so many Vermonters. Healthcare means nothing if you can't get to it. And we often think of ourselves in public transportation as the connective tissue for the actual work that gets done, but without the connective tissue, it can't get done. So we're grateful for the time and opportunity, and if we need to come back, I'll look forward to seeing you all again.
Great. Thank you.
Thank you very much.
Okay. So next we have with us Beth Anderson from Vital. And Beth is going to explain to us all about Vital.
Best.
Proceed.
Thank you.
Thank you for coming in.
Thank you for having me. You're ready for me to put my slides up? Is that?
Yeah, great, it's fine. They're also posted on our website if anybody would like to follow along.
That's how it works.
Yeah, go ahead. Yeah, you can go ahead and start. Thank you.
I'm Beth Anderson. I'm the president and CEO of Vital. We are the health information exchange for the state.
I'm sorry, I'm just counting because I
Oh.
realized that we lost a quorum in the room, but we still have one on YouTube.
We can keep going. Great. Thank you. What I wanted to do, or what I'm going to do today, is walk through a little bit about who Vital is, what health information exchanges and interoperability is, and then talk about some of the work that we do with healthcare providers. So give you a sense of kind of the bigger picture of interoperability, and then some of the real specifics about what we're doing now, what we're hoping to do, and what are some of our plans are. So just to start, Vital is a nonprofit organization. We're a Vermont organization. We are designated in statute to operate the Vermont Health Information Exchange, which is a network that shares healthcare data across. I'm going to say healthcare organizations in the state, get into in a bit just what that means, who participates and who uses the data. Just as foundational, because I know I live in this and I don't want to assume, thought I'd take a minute to talk about what health information exchange is. And so I'm using some definitions that actually are used by the Assistant Secretary for Technology Policy, who's part of the Federal Health and Human Services Organization, right? And health information exchange, or HIE, can really be looked at as a verb, which is really the appropriate and confidential sharing of electronic health information. But it's also a noun. HIE can be an organization such as Vital that actually enables the sharing of that data. So really what health data interoperability is, or what it means for us at Vital, is enabling the sharing of health data across health systems. And by systems, I'm both talking about organizations, but also technical systems, right? So we basically work with provider organizations across the state, and also in some of the at some of the borders, providing care for Vermonters, to collect data about the care that they are providing for Vermonters. And that can be information from hospitals, from independent practices. It can be from labs, pharmacies, things like that, that we're collecting data. And what we do is a lot of work to make that data meaningful and usable across all of the stakeholders. So as you can imagine, each system at different organizations collects data, or can collect data, in very different ways. They may call things different things. They may use different terminology for referring to types of data.
In some places, they'll use, an example of that, a lab test might be called by the actual name of the test. In another organization, they may use local codes that are numbers. Others may use national standards for how they refer to those. So what we do at Vital is we build connections to these organizations to collect the data, and then we standardize it, normalize it, and match it. So what that means is we can take those local codes by working with those organizations to understand how to translate them into standards, so they're comparable across organizations. And a very simple example of that, and I don't mean to trivialize it at all, but is if you're capturing gender, right? An organization might capture male, female, non-binary. Another one might capture MFN. Another may say 1, 2, 3. We can take those, work with the local organization, say, okay, you use 1, 2, 3, but we're going to use the standard, or the national standard is this. Let's map it. So then when we have a complete record from patients from across providers, it actually is comparable and makes sense together. And so that's kind of what we do to make the data more usable by all of the stakeholders, saving them from having to like map their systems to standards or figuring out how to match them across. Another thing that we do using some very sophisticated tools that we license is match data across provider organizations. So we have an industry-leading tool that we license that allows us to take information from different organizations and understand if records are likely the same person. So someone may have gotten care 3 years ago in Rutland under the name Jay Smith, moved to Burlington, uses John Smith now. But because of the data that we have to do this matching, we can know, well, that is a good old address for this person, so this record is the same. Or, you know what, like we don't know enough to be sure. We are not going to match these records. So that really helps us to be able to really create what is our goal is one complete health record for each Vermonter that has the kind of their longitudinal record across providers. I will say, if this is okay, you want to stop me? Yeah.
I have a question on that. So Vital collects all this information. What do you do with it then?
Yeah, we house it, and I will get to how we secure it and share it and in this presentation so you understand fully what that looks like. But we do keep it in a very secure manner. We have all sorts of protections for privacy and security of the data in place. Do you mind if we wait to get there? Okay, I promise I will try to answer your questions. So some of the value of what Vital does as an HIE is that we really are a data sharing hub. So some HIEs operate by just passing data between providers and not really storing it and not keeping that longitudinal record. And what we do is we collect this data. So we have that full history of data, but also we really provide some burden reduction for providers because they can submit data to Vital, and that will save them from then having to submit immunization data to Department of Health or reportable disease information or sending their data to Blueprint or sending their data to a payer that they interface with. And so they can maintain one connection with Vital and not have to maintain all of those multiple connections. So it really can reduce technology burden, staffing burden, and just remembering to have to do some of that data. So there's a lot of value to providers in participating, in addition to that they do get access to the data so that they can inform their patient care through using the data. Just a little bit of information on who participates and what types of data we have I thought might be useful. So just to give a sense of the participants, this list is pretty current. On the left side is the organizations that contribute data to Vital. And on the next slide, I'll talk a little bit about types of data we get. On the right column is who accesses data. And so we do have connections to all of the Vermont hospitals as well as Dartmouth to collect data on Vermont patients. We're connected to all the FQHCs or the federally qualified health centers. And I'm sorry, I always forget to do this. When I talk about hospitals, that doesn't just mean the main building of the hospital. That is typically their associated practices, so primary and specialty care practices that they maintain. We're connected to independent specialty and primary care practices, home health agencies, nursing homes, pharmacy chains. The number thereof is actual chains, not locations. So we may have a connection with CVS for many of their locations, but they would count as one under that. State and community laboratories, the Department of Health is a big partner that we have that we share data with. The designated mental health agencies use our data pretty robustly. Emergency medical services use our data, and that's been a growing use of our data over the past couple of years, and really through COVID. The EMS teams typically don't have patient data on hand when they go out on a call, and so they've been able to use the BHI, the health information exchange, both to inform when they're going out to deliver care. So they might know if someone has certain conditions or allergies that they should know about. They're also using it to do quality improvement. So typically they didn't necessarily know what happened to a patient after they dropped them off at the hospital. Now they can go in and see what happened and say, oh, could we have done something different when we transported this patient in their care that might have led to a different outcome? So it's really great to see how it kind of informs the different components of their care. We also do work with commercial payers. We work with Medicaid at the state, and we'll work with a commercial payer. And so
Another question.
go ahead.
On that last slide. If somebody is, for instance, a designated mental health agency is not contributing any information, and then 12 of them are trying to access information, where's the information come from?
From the other providers across the state. So it might be from a hospital or a doctor's office that their patients are looking at. So if they're providing care to an individual that sees them for substance use disorder support, they may want or need to know if that patient is using other types of medications or prescriptions that they want to see in their record, or who their primary care doctor is if they had questions about coordinating care for that patient.
So it depends on whether or not primary care physician or whatever kind of physician is contributing to this.
Participates, yes.
Well, there's no information to access, correct?
Right.
Okay.
Yeah, we work with all of the organizations on the left to collect data, and that is all we do have available. Did that answer?
Well, I won't say unfortunately. I was part of setting up Vital. And my understanding at that time, it was supposed to be so that the patient's medical record coming in from hospitals and all of that, you were the hub for that, and it would go out to whoever needed to use it. And I'm not getting the feeling so far from the presentation that that's what you're doing.
Oh, that is absolutely what we're doing. And I can go through in a slide or two. Well, I'll talk about what types of data we do have, and then I'll talk about how providers have access to that data from all of these organizations.
Sure.
There's a reason, so just to touch on the mental health agencies, and if you don't want this piece of information, stop me. There are federal regulations on how substance use disorder data, treatment data can be shared that's different from traditional healthcare data. So that when you go to your traditional provider, and that's the reason we don't have the data from the designated agencies in the HIE right now. That is shifting on a national level, and we're actually working with them to plan to get that data in. So there's a specific reason that number is 0. Does that?
I'm listening to what you say.
Okay.
I don't know how you get information if the emergency medical service agencies. That will go into the patient's record.
They don't have a system that they collect patient data in. So we don't have a way of getting data from them. They typically will document, and if anyone has different information, they will typically document in the health record at the hospital or where they drop the patient off. So we would tend to get information from that patient on that experience, but from the hospital, not from the EMS agency.
Okay. Thank you.
Woody?
So Vital collects data and you can share it with the hospitals. Why is it necessary for some hospitals to have a separate system? Could Vital be the primary system for all of our hospitals and all of our healthcare needs? And I believe there's been some discussions on that regarding lowering some of our healthcare costs.
And having a single EHR. We do not operate as an electronic health record. And so they have a lot of capabilities that in support of the delivery of care and all of the work that happens in caring for a patient in a hospital that are not capabilities we have in the HIE. We're built to collect the data that is captured in those systems. So we don't have an interface that allows anyone to kind of document about patient care or track a record of care. So Vital could not serve as that piece of information to support the patient care directly. We were created to really collect the data for all the points or the different experiences a patient has across the continuum of care, to consolidate that information, to have a more complete record to help inform patient care.
Thank you.
Yes, go
So
ahead.
is that your only, I mean, you collect data to share with other entities. Do you use that data for anything else?
I get to the
Okay.
slide where I talk through some of how it is used, if that is okay.
Absolutely.
Great, thank you. So just to go over the types of data that we do get, and data typically is collected and shared in some standard national or international standard formats. And so we may get what's called an admission discharge transfer message or an ADT, which is just that someone is admitted into a care facility, they're transferred to different facility, they discharged from a facility that will have some basic demographic information as well as typically information on why a person was admitted or discharged. We will get patient record summaries, which are called CCDs. And if you haven't seen one, it's a way to think about it is oftentimes if you go to your own care appointment at the end, they offer to give you a printout of your record. It's all the information that's in your record. So it's not only about that, that kind of interface you've had that day, but it's your historical allergies, conditions, medications, things like that. We get lab and pathology test results. We get radiology reports, so that is not the images, but we get the written reports about the reading for the radiology reports. We get clinical notes and transcription, so that would be the details that might get typed in with some more descriptive information about the experience. We do get some home health monitoring data, and we do get immunization records pretty broadly.
And if I didn't want you collecting my data, can I still opt out?
Yes, I will go into that in a little more detail in a moment, but you can do that in two ways. You can with the healthcare facility, ask them to not share your data, or you can ask Vital to not share your data. There are two ways around that.
And if I may,
Of course.
do you share it outside of the state agencies and hospitals? Federally, perhaps?
We do work with the Veterans Association and the Department of Defense. We do make data available for their care of patients in their facilities, but that is the only place we do on a national level. We do have a couple of border hospitals or providers who access the data as well to provide care for Vermonters, but we don't participate in any national data exchange or the like at this point.
Yes.
Okay.
So if I am in New Hampshire,
Yes.
I go to a hospital there. From reading this, my patient record is available to that hospital in New Hampshire?
We work with two hospitals in New Hampshire. Dartmouth Health, they typically use it or do more submitting data to us and are not using our data as much. We do work with Cottage Hospital, which is at the border a little further south, that does access our data to review patient records. They do provide care to Vermonters.
Okay, could you just say, what about Dartmouth? You just mentioned Dartmouth. Go ahead, you say it again.
They submit data to us, so they provide information to us about Vermonters that receive care in their hospitals.
Mhm.
They do not use as much of our data. They in some of their facilities, they do use some of our data where they're providing care, but not across the board at Dartmouth, as robustly as Vermont hospitals do.
Is there any time that they would use it?
Some of the providers do use it for providing patient care. But it's
I thought that's why we were setting up Vital, was to make sure if somebody was I live in central Vermont. If I'm in Bennington Hospital can access the information about me. I'm unconscious.
yes,
They can do that
again,
through Vital.
yes.
But Dartmouth doesn't do that.
They do, some of their providers do, but there is not broad coverage within Dartmouth for using the HIE data.
It's interesting.
Can I
They were
ask,
part of our
do
healthcare.
you understand why? Is it, do they have problems with access, or is it lack of knowledge, or where do you think that problem
Yeah,
lies?
I think there's been some change in leadership there. We were trying to build some new connections. I think historically, New Hampshire has not participated in health information exchange as much, just as a state and as providers. I think we have some opportunities to continue working with them.
So they don't have a statewide plan like this?
They don't. They do
So it's
not.
not their natural go-to?
No, they do not have an HIE. They have not had an HIE for a long time.
Mhm. Thanks.
Do you sell our data?
Oh,
No,
my God.
no,
I'm just curious.
no, we do not.
Thanks for getting that on the record.
Yeah, I'm happy to talk about that all day. We do not make the data available for commercial uses.
Okay.
Right now, we don't even support research. There's opportunity to do de-identify data for research in the future. We are not doing that now.
But you may be considering it in the future.
Research,
Yeah.
yes, not commercial, but more academic research. Fun?
Let's move on.
No, it's a great question. Get out of the way. So just to talk through, this is where I'll talk about a little some of the services that providers can use to access the data. One of the main ways is through this Vital Access Clinical Portal, which is basically a website that they can go to. They have with proper like association with a practice, they can get a login to actually access patient records. And in a couple of slides, I can show you some screenshots that'll give you a sense of what's in there. But it basically has allows them to search for patients and get a full patient history. They can view information in that portal. They can also download some documents into their systems as well. We have a service that delivers test results, imaging reports, and notes into electronic health records. So where a provider might subscribe to this, we can actually, when we work with, say, a lab at a hospital that might be doing some blood tests, we can take those results, deliver them right into the community provider's EHR. So that's a benefit for providers, well, because they get the data in a very timely manner at the point of care in their systems without going into another system. It also saves the labs, the hospitals, time of delivering out those reports. So they might be faxing them or maintaining connections, and we can do that on their behalf. So providers have access to it. We can deliver clinical summary documents into EHRs. A couple of organizations or hospitals take advantage of this. And that means they can actually, from their EHR, so the system they use at their facility, query the HIE to get patient data and pull into their records directly. So not having to go into our system separately. We do NEHR immunization registry queries. So this is a new service we've put in place starting last year in partnership with the Department of Health. And so typically providers have had to go into a specific immunization system that VDH maintains to get information on the immunizations a patient has had or the forecast of the immunizations they may need. Now they can query from directly in their EHR to the Department of Health through Vital and pull back a patient's immunization history and forecast without leaving their system. And what we're finding has been really great for them is they can do that while the patient's there for an appointment, but they also pre-fetch it often for the appointments coming in during the day. And one of the organizations that we are working with that has taken advantage of this is estimating that their nurses are saving about an hour and a half a day, not having to go pull this information out of the immunization registry. So you can see real benefits to the providers and the care that the time they're able to spend with patients now.
Leslie, would this system be able to know duplicative work if a image was done in one hospital and then repeated within a day in another hospital? Could that be noted?
We don't track that at this point. Something that we are looking at doing kind of as some of our next step work is building some dashboarding capabilities, working in partnership with a project that the state AHS has planned, which might allow us to do more of that flagging, like, oh, this person hasn't had their colonoscopy and they're due, or has had this test recently, to help inform that information.
Yeah, I really worry about when someone gets evaluated off the top of my head in Bennington, then they get transferred over there, everything is done again.
Right.
And that's obviously true waste. And how can we think about that?
Right.
Does this help us think about it?
Yeah, I mean, I think that's why we hope providers and we really encourage providers to use our tools and our portal because they can see what's happened elsewhere. And the hope is that we can help, provide, minimize the duplication of tests. It's hard for us to know. I'll be completely upfront. It's hard for us to know because we don't know what care hasn't been delivered because of the use of our tools. But, we've worked with HIEs in other states and some have done some studies and shown real improvement or real reduction in duplication of testing because of use of the HIE.
I'm curious, regarding the interoperability or the interface, I should say, between the information that Vital has and the HIE and the different EMRs or EHRs that people use. Who's setting up the interface? Is it on the provider end? Is it your end? And how many are you even interfacing with at this point? How many have you got to go?
Yeah, that's a
There.
great question. That's a great question. So typically building the interfaces is work on both sides. So at the provider organization and or their EHR vendor and Vital, we do work together to build the connection, make sure it's secure, make sure we're mapping the data properly. So we're understanding what codes they're using, where they're keeping the data. So we're getting it into the right spots or cells on in our systems. So that is a shared responsibility that we have. We maintain, I have to check the most current numbers, probably about 800 or 900 interfaces that collect data or deliver data. And those interfaces can be for one set of data or a host of types of data coming from an organization, depending on how they deliver. As I mentioned, we know we work with all of the hospitals and all of the FQHCs. The independent practices are hard to know because we don't have a list. There's no one list in the state of all the independent practices. We have good coverage, particularly of the larger practices. We know there's more we can do. I'm going to go off on a little bit of a tangent here. We have new this year, someone on our staff who has come in to focus on outreach. And her title is a clinical education lead, and she is actually a trained nurse who has been working doing clinical education for years. And she is actually doing a lot of outreach to go on, not just tell people about Vital and our existence, but do training on how to use our tools and how to integrate them into their workflows, which is, I think, is something that we find that it's one thing to say you have an HIE and somebody thinks, oh, great, but if you can show them how they can use it or what kind of data might help them, it's been more helpful for uptake. And so we've had a lot of focus on that, which I think has been really great and helpful for us to build more participation and activity. HIE.
Thank you.
Did that answer?
Yes.
Okay. Great. So the last two things on this list, just, one is event notification. We do this through a partner, and facilities can sign up to get very timely notification if a patient that they care for ends up in an emergency room or having a care situation. And this is really helpful for organizations that do care coordination, community providers, so they know if a patient that's on their roster that they're following does have a care event, so they can call and follow up and make sure they're getting the care they need. This also can be used, payers will often use this too to help. Oh, one of our members has ended up in an emergency room. We should call them, make sure they're getting the care they need. Do they need help accessing care? So that's been a great service for us. And finally, we do some custom reporting. So we do some extracts of our data for some partner organizations who use the data. We can do these extracts that they can import into their systems and do kind of the analytics and reporting they may want to do either within their systems or combining with other sets of data that they have to do more robust work.
Woody.
Curious, is there a fee for the participants?
Typically, there is not a fee for providers. The one area, well, I guess two areas where there is a fee. The event notification is through a third party that we partner with. So there is a fee to have that service right now that they pay to that third party provider, not to Vital. And when we do custom extracts, we often do have some charge for the work that our team has to do to build those extracts and maintain those extracts when they really are custom for someone's needs.
And who pays it? I guess the participant, whether it's the FQHC or.
Yeah,
is there any-
Yeah, organizations
support.
we do this for, so provider practices, hospitals don't pay for our services at this point. It's that third party, and a good example of where we've done extracts in the past is One Care. They had some very specific needs for their patient population. They wanted data in very specific formats to pull into their systems and use in their workflows, and so we would recharge them for some of that custom work.
Right, and since you mentioned One Care, are you going to do business with the new AHEAD model?
We are talking with the state about what our participation will look like, yes. So we're hoping to support that. No? Great. So this may address some of your questions about access to data and how data is shared. So the access to the data in the HIE is governed by a number of different things. It starts with HIPAA, federal regulations, but that is kind of the floor of how we do things, and we do things more, we take it a little more seriously here in Vermont and at Vital in the way we do things. So we have agreements, services agreements with each of the organizations that contribute data to Vital or use the data that we have that are very restrictive in how the data can be accessed and used. We also have Vital policies which control some access to the data that again are more stringent than HIPAA allows. And then we also in the state's HIE strategic plan that is approved and prepared by AHS and approved by the Green Mountain Care Board also provides some guidance on how the data in the HIE can be used by providers. So we do have some very, very kind of clear guidelines. To your point earlier, it prohibits commercial use of the data. We are restrictive in how payers and ACOs can use the data, because some of HIPAA might be interpreted by providers to allow payers to use the data for payment operations that might be considered could be negative impact to providers, and we don't want that to happen because we want providers to participate in the HIE, so we limit how some of the data can be used even further than HIPAA allows. Individuals' data and the HIE is only available to authorized users. So again, we follow those rules and regulations. It's not available to the public. We do not sell it. And currently 98.9% of Vermonters are sharing their data on the HIE. I won't read through the slide, but this gives you some information. We have a very robust security and privacy program at the HIE for how we maintain data and how we hold our participants accountable for abiding by our regulation, our standards and our rules. And finally,
Have you ever been hacked?
no. Nope, we haven't. We've been very lucky. We just keep knocking on the wood. I'm sorry, but yes, we have a good program in place. We work with partners who have strong security in place, but we also know it's a world where it's a risk every day, and we take it seriously. We do ongoing patient education. This is unique in Vermont for how we as an HIE do this, but we make sure that we are doing regular outreach to patients and making information available to patients so when I say patients, I mean individuals, Vermonters, so they understand how their data is shared, who has access to it, and that they have options about whether or not that is okay. And we do that on a regular basis, and we use I'm sure you've seen or heard some of ours, like we advertise on VPR. It's not advertising, but we sponsor VPR. We do use Front Porch Forum. We've had some campaigns in local newspapers. We've actually had some publicity on some of the local news stations about our work. We really want individuals to understand how their data is shared. We think it's very important. So part of the education is so they understand the value of why their data is accessible to their providers, but we want them to understand that they have the option to not share it, and they can very much do that. And we take that very seriously. So this is just to give you a sense of the portal. I am not going to give you an in-depth demo of the portal, but sometimes I think it's helpful to see like what actually providers can access and what that might look like. So this is just if a provider were to go into the portal and do a search on a patient, and this is a test patient, there's no real data in here. And it just gives you a sense of what that screen might look like. You can see on the left, it's just kind of a list of the results. On the right, the immunization record, some of the documents. So if somebody wanted to pull a document in the system and see the full history, it might be there. But then you can actually click through and see more details. So this is if they wanted to drill into some of the results of the recent tests a patient had. So you can see there's a list on the left of the tests that have been performed. click on that on the right, you can see the actual results.
Okay, that was my question. I just wanted to see how that looks. So that whole left side is active.
Yes,
Got it.
yes.
Thank you.
So that kind of addresses your question earlier, like if you could go in here and see, these are all the lab tests this patient has had in the past. You can see. how
12
long it
hours
might
ago in
be.
the other ER.
Right,
Yeah.
right, exactly.
Yes. Your example is a perfect example. So what are you using any of this data? And you talked about working with Blueprint for Health. And then there was OneCare. Are you using this data for quality measures? I mean, I'm looking at hemoglobin A1C right here, which is a quality measure. Is it being shared for pulling quality measures?
Besides the Blueprint right now, we are not doing anything around quality. Some of the organizations we work with do use it for how they're measuring their quality. We are also, as part of that Unified Health Data Space I mentioned, that we are working with the Agency for Human Services to kind of plan for and build towards. We are going to be looking to do more quality reporting, making the data available for providers and potentially for payers to be able to do their evaluation of their quality programs. And some of it may be more specific, doing some of the measurements that they have to do for quality. Some of it may be more dashboard, so they understand, looking at your patient roster, how are they getting the tests they need, or do you need to do some feedback? So it may not be the actual calculation of the quality measure, but the information they need to perform towards those measures as well.
That would require everyone to submit data, though. I mean, if you're ordering a test at a lab that is just looking at data but isn't actually submitting their data, you wouldn't.
Right, which is why we're continually trying to engage organizations to submit more data to us or to start to participate with the HIE. It's work we have not stopped and will not stop to do. And, we've been lucky that we've had partners in the Blueprint program and traditionally OneCare to help encourage their participating organizations to submit data, because we deliver their data on their behalf. We do that with the Department of Health, and they want to prioritize organizations because they're participating in more programs, so case reporting, things like that. So that is how we engage in a lot of the conversations to get practices to participate.
Thank you.
So I did not segue that intentionally, but now we'll talk about the Department of Health and some of the work we're doing with them, because we're really excited about this partnership. And I think this is a real example as a state where we are leaders, and the partnership and the work we're doing as an HIE with our public health department. We've been really lucky. We did a lot of work. You've heard me, many of you have heard me talk about before, the work we did with the public health through the pandemic, right? And getting them the data they needed, so they weren't having to focus on getting data, they could focus on the public health work that they needed to do. From that, we've had a lot of opportunity to kind of realize there was a lot more opportunity for us to work together. So Vital could support their data needs, both getting data in for public health purposes, but delivering some of the public health data out so they can really focus on the value added work that they do using the data and preparing the data. So one of that is, I just talked about a few minutes ago, with actually access to the immunization registry from the EHR. So providers no longer have to log into separate systems. We are working with them now to help get lab reporting for the reportable conditions. So there's a whole host of conditions that have to be reported to the Department of Health within, I think, 24 hours of testing. Organizations need to do that manually or electronically now directly to Department of Health. We're actually working to help do that reporting from the HIE, so they don't have to be collecting it from different organizations and don't have to maintain different connections. They use our provider portal in a lot of their programs to help inform their public health work, the medical examiner, WIC, the case reporting and epidemiology team. They continue to use the provider portal for their purposes. We are working with them to be able to potentially use some of our data to inform more population health activities, so more aggregated and de-identified data, some pilots that we're doing this year, which are pretty exciting. We are working with the WIC program, Women, Infants, and Children program, to get them data directly into some of their systems, which is not only going to help them deliver their program, but also going to save for the families enrolled in the program from having to go in for appointments, because we'll be able to deliver data that will keep them enrolled instead of them having to necessarily show up for appointments on a quarterly or half-year basis to kind of fill out paperwork or show their test information. So we're really excited about that, because the impact, not just to public health, but really to keep people in that program and registered. And what's really exciting is we, 2 years ago, a year and a half ago, worked together to put a strategic plan in place to identify future opportunities for us to work together again. So public health so we're not maintaining duplicate infrastructures and technologies. Vital will focus on getting the data, the things that we are good about, maintaining the connections we have, and delivering the data the public health needs for their purposes, or getting the information from public health out to providers that they want to get out. So good examples are we've integrated the death registry with the HIE, so we have that information available for providers. We're working on births, immunization records, and we're continuing to expand on some of that work over the next couple of years. And so I promise I'm almost done, but I'll just spend a couple of minutes on some of the work we have going on now in areas we're hoping to focus over the next couple of years. One is taking information on social drivers of health or social determinants of health. We all know that, and I saw on your board, like we all know that this is an important part of the delivery of care, is knowing not just the clinical information about an individual. And so we are working now to start working with organizations across the state to start collecting some of the SDOH data into the HIE. Our first focus is the CMS, health-related social needs screening tool, which most of the providers across the state are collecting. They need to collect their payment goals and have agreed to use a standardized survey tool. We will be collecting that into the HIE and making that available, and we will work from there to kind of prioritize additional information and get that in. Other pieces of work, we're continuing to integrate new data types. We talked about the part 2, the social substance use disorder data. We're hoping to, with the new rules from the federal government, be able to have that in the HIE in the coming year or two. We are looking at opportunities to really get more data into the providers' workflow, right? That is one thing. Like, they can go into our portal and get data. They can use some of our tools to get data, but they want to stay in their EHR. We don't blame them. They don't want to have to log into a different system. They don't want to have to think about where else to go. And so there are a couple of ways we're looking at doing this that we have underway now. One is simple things like single sign-on to our tools. So instead of having to log into our portal, they could have a button in their EHR that automatically logs them in to the patient that they're looking at in their EHR. Still have to look at a different screen, but without the logging in and searching, so it saves some time. We're also putting in place, I will not bore you with the technology, but application program interfaces, or APIs, which will allow them from within their EHRs to query the HIE for data. And that could be complete patient records. They may decide to just query things like allergy lists or I'm so sorry, lab results, things like that. So really to get them the custom information that they want, but again, at their fingertips in the patient record, instead of having to go into different systems or pull through different information. The final kind of big project that we're working with AHS on, you've heard me mention a couple of times already, is this unified health data space concept, which we are kind of in the process of really working with the healthcare community to understand kind of some of the data needs and reporting needs that different organizations across the state have, to try to build a capability that delivers on some of the analytics and dashboarding needs that providers have. And we know that providers across the state are going to have very different capabilities and very different needs. Some are just going to want dashboards like we talked about to say, of my patient population, this is my patient population who's over 50. Should they had their colonoscopy? And that will be what they need for their workflow. We know other organizations are going to want to do more advanced analytics, but they're going to have systems that do them. They're going to want to have ways of downloading the data from the HIE into their systems to inform the care of their patients along with their other records. And so we're really working now to kind of define this capability that kind of meets the needs across the spectrum of providers, to kind of help provide them with additional information, more actionable information that also delivers on kind of where they are and what they're doing. So with that,
I know that Brian has a question, and Brian, I'll call on you in just a second, but I did have a question just around, there's been a lot of conversation recently around interoperability, even a sort of a universal health record. And I guess my question is, if we have Vital And if Vital is being used to its complete capacity, do we need that?
My answer is biased, obviously, but no, I think the real value of having a health information exchange that does what Vital does is different providers and different practices have different needs from an electronic health record, ignoring the fact that nobody wants to, or very few are going to want to change the systems that they use, right? Because that is expensive and burdensome. Like, I'm not going to argue.
Well, true. Just saying.
There are studies that show like you lose providers when, like a lot of providers, when you do those
Okay.
changes, like, yeah. Like, but what we do is like, we allow each organization to use their systems that they are comfortable with, that they can afford and support, and use it in the ways that support the way they deliver care at their organization. And we can help translate and map that data so it is still usable by other organizations. So that's where Vital comes in. I'm not going to argue that you can't have one EHR across. I can come up with lots of reasons why it's a really hard solution to have one EHR across organizations, ignoring kind of the expense, the resources, but just the ongoing ability to align practices and data governance across organizations is huge. But having something like Vital that we can get data not only from EHRs, and that includes EHRs that are certified by the kind of the federal government programs, but also the EHRs that aren't. They're some of the less expensive ones that smaller organizations, smaller providers, single provider organizations use to get data. Like, we can get that data into our system. We can take data in flash files. Like, if we have a provider who's capturing data, I don't recommend this, but in an Excel spreadsheet, we can get that in, right? And so that's where having an HIE really is valuable to the state, because we do that kind of last mile work with these organizations. We sit down, we understand how they're capturing that data, and we can get it in a standardized way that makes it usable.
Thank you. Oh, Brian has a question. Let's,
Thank you. Can you hear me okay with the headset on?
yeah, hear you perfectly.
Okay, I have 3 questions. One is related to what was just being discussed. So I'm just going back to my notes because I wrote them down to stay focused. All right. So the first thing is, you were just all talking about why Vital might make a unified health record unnecessary. But I guess what I was going to say is there's a difference, and there's a question here, but like to frame the question, there's a difference between a provider keeping a record that then other people can access through some kind of common database like Vital, or that data could be extracted from by people through Vital, and giving a provider technical support to maintain a health record, especially with the disposition of records at the end of a practice or a place where things like, in other words, providers still under current law have a burden to maintain a record of their clients after they even close their practice. So like, I don't think Vital is replacing the need for that yet. I think Vital has the potential to do that, but you would have to do a lot more than what you're currently doing. And I guess the question I have is there, I'm going to put my 3 questions out there at once and then let you answer them at once because it might be easier. The first question would be, is there any way that people are looking at expanding Vital? It sounds like you're not looking at a unified platform that everyone uses, like one kind of consistent medical record, but is there any way that Vital is looking at offering a place for people to permanently dispose the records or other services to providers besides sharing information and extracting data? And then the second question would be, how is artificial intelligence being used by Vital? I know that it is being used in other health records, and I'm hoping we can take some testimony on that soon. But how is it being used in Vital? What safeguards are in place to make sure that one person's AI isn't extracting data from other people's records in a way that circumvents the intent of people when providing that information to providers? And then I'm also curious, you mentioned HIPAA, but we didn't hear about high-tech, HITECH, health information. I can't remember what the other things mean, but it was like the next generation of HIPAA. And it's the federal law that led to the promotion of electronic health records. I'm curious what the latest updates to high tech are and how that might weave into what Vital's doing. I
Okay.
waited till the end. I didn't want to interrupt, so I've been writing these things down. Okay, thank you.
Thank you. I'm gonna do my best, but will you promise to keep me honest if I miss something?
Well,
Yes.
yes.
Great. So Vital is not an electronic health record, answering the first one, right? We collect the data from the electronic health records, and we are not looking to replace the electronic health record or the EHR at provider organizations. That is not what our mandate has been. And that I think would have us doing what the commercial market's already built and is effective at doing. Collecting the data and making it available and aggregating it so it can be used by organizations is really where the value in an HIE is. Now, have we talked about doing anything beyond the sharing of data? We don't right now. Your point on the disposition of records is interesting, and I think that's something we would have to discuss with a couple of attorneys to see if that would be if the practice could use that as their way of managing the disposition of records, but certainly something we'd be open to talking about because we do maintain the data in our records. Moving to the second question around AI, we don't use AI in our work now. We do use a bit of what you would more term like machine learning, and that's where we do things like standardizing terminologies. So we will use lookup tables that say, well, the local organization has captured M for male, but we're going to translate this to male so it's consistent across. So we're not participating in a kind of public AI activity that is tool that we use that is focused, that we control, that is specific to our data where that happens. Patient matching is another example where we have a database that we do comparisons against to say, okay, we have this patient's record coming in today. What do we know of, like, how can we match this to another record to know it's the same person? Not sharing that data outside of Vital. It's not public. The third question I might need clarification on. So HITECH was not meant to be rules around data sharing. It was really a program that was meant to encourage the use of health information technology and to do that in a kind of appropriate ways that honor security and privacy of the data for sure. But it was really meant more for helping support providers to have access to health information technology in their day-to-day work. So that might have been implementing an EHR, moving to a CMS certified system for their technology, putting in place the capability to share their data with an HIE or others to support interoperability. The HITECH program expired, I want to say it was 2 years ago now, but I'd have to check that to be sure. So that program no longer exists at a federal level. There are some new programs that are in existence or starting to come into existence at a federal level, really to encourage interoperability. TEFCA being one, the Trusted Exchange Framework and Common Agreement, looking to encourage more national data sharing. I think that's something we'll be talking more about in coming years. Now, one thing that the HITECH program did do was provide funding to provider organizations to implement the technology. And I do want to give credit to the state because AHS has put a program in place that started last year that still exists. It's called the MDAP program, and I will get it wrong, but it's the Medicaid Data Access and Accountability Program. I know I have the second A wrong, and I'm sorry. But where they are making data kind of program support, as well as funding available to providers to implement technology, health information technology, so they then can participate in data sharing. And they've used that in particular to kind of support some of the organizations that might not have been eligible under HITECH or already under HITECH. So behavioral health is a really good example of organizations they're working with now to get onboarded to new technologies in the HIE.
And Leslie. I think what my question was, and I'm sorry if you have brought this up before and I missed it, but where do you see your funding from?
Oh, so we are funded through the Agency for Human Services.
Okay, so it's just part of our general.
Most of our money actually, so the funding for Vital is largely comes through CMS, Centers for Medicaid and Medicare, through Medicaid. So it depends on which piece of our work it is. It's anywhere between about 72 and 90% of our funding actually does come from CMS through the state.
Through the waiver.
The waiver or other programs that CMS does make available for this type of work.
All right, great. Thank you.
Is there a special fund?
Health
for
Information Technology Fund,
information?
yes. So the
Yes.
claims
Does it have
tax.
Funding for that.
Yeah,
tax,
the claims tax is
I knew
used for
there
the
was
state
something.
match for CMS. So the claims tax, a small portion of the claims tax goes into the Health Information Technology Fund, which is used to fund the state match for vitals work and some other work that the state does. A good chunk of the claims tax does go into the general fund for the state as well.
Robert?
That was my question.
Oh,
I knew when we set it up, it was the claims tax, or whatever you call it.
Yes. The state's been lucky to be able to leverage that with CMS funding.
Once again, I'm not sure if you said, I'm looking back at your slides, but how much staff do you have and were they with this that year or
That was not there. I'm
Okay.
sorry. So we have about 30 staff
30?
right now.
Oh, that seems like a lot.
Yeah, we do a combination of work. Some of it is the hands-on work with the provider organizations to build the interfaces and map the data. We're building 150, 200 interfaces each year. I'm getting data in and out of the HIE. We have staff who maintain the systems and just keep them operational and running. We have security, privacy, or staff who do just that, which are important. And then we have some staff who work with the healthcare organizations to do training on how to use our tools or how to work it into your workflow.
So are your staff, so do you have clinical staff like nursing so they would understand a chart or how does that work?
We do have staff who have clinical experience. So we have a couple of nurses in particular on our staff. We don't do, their work is more to help understand the data that we're getting in when we're doing the data mapping or making data available. We don't do clinical support.
So for your
or
team
clinical
to
work.
understand.
Yes.
Yeah, got it.
Yeah.
great. Well, thank you. And thank you for coming in.
Thank you.
And with that, I think we can